So I'll present our experience at Prince Sultan Cardiac Center. Okay, nothing to disclose. And as an introduction, we know that the surgical bioprosthesis is a success story, being more and more used for mitral valve replacement, but with time, certainly they will degenerate. And we know that the risk of redo surgery is higher than first surgery. That's what makes probably a window for the mitral valve as an alternative for these patients. We started in March 2017, and what we discovered, in fact, and we advise people who are interested in starting this program, is to have a heart team. And what makes it easy for us is that we have almost complete and signed operative report on all those patients with mitral valve and valve. And we have the label of the valve, the type, the name, and the size of the valve on that surgical report. If we didn't have that, then we have to do additional investigation to confirm the size. Now, this might be probably, in few cases, might be risky, because if you look to the center which do mitral valve and valve, they demand the CT scan for measurements. But you'll see from our experience that we have never done a CT scan for all of our patients. And the reason is that we're really convinced that the data we have is enough. Now, there is always a chance of having putting the label for the wrong patient, but when you have any doubt, certainly we should do CT scan. This doesn't mean that I discourage people from doing CT scan, but this is our experience. We didn't do any CT scan in these patients. But we, in detail, go to their surgical report, and we make sure that the label is clear there. Certainly an imager, cardiac imaging expert is very important, and all our cases was transeptal. I have to acknowledge or thank Dr. Rida, who's one of the panel, that we did the first case with him, which made it easy. So he's a proctor of people who are interested in starting the project. I would recommend Dr. Rida Balata. So we started from March 2017 up till now. We did 20 patients, 18 patients underwent mitral valve and valve, and 2 patients mitral valve in the ring. This, the type of the valves, so it's a small number, you cannot figure out, but we use almost all valves, and the rings should be like a semi-flexible or flexible ring to be able to adopt the valve. And in spite of that, as Professor Corti mentioned, there is a higher complication rate when you put valve in a ring, and there is a higher paravalvular leak. So you should be, if you want to put really mitral valve in a ring, you have to be prepared to, you might need additional procedure, which is a paravalvular leak closure device. These are, you see, the years, so you cannot figure out anything of these, but I think the old generation tissue bioprosthesis probably is better in quality than the new generation. This is what we felt, you see. Don't judge, but we found that mosaic is not a good valve, and surgeons start to look into different valve to be implanted. The baseline characteristics, usually our patient's median age is 71. All of our patients are older than 65, and this should be the case, and in fact we should be probably more than 70 even, because these should be a high-risk patient to be able to include them into mitral valve and valve. Majority being rejected for redo surgery are usually ladies, because ladies, they tend to have a higher surgical risk from redo surgery. Others is probably a chronic renal disease or diabetic patients. The mean risk, if you want to stratify them, according to surgical STS risk score, is around 7. So this is the clinical or surgical history, hospitalization. Most of them, they needed hospitalization within the past year, and a lot of 30% of them have significant kidney injury. Some of them, they have previous stroke, but it's less. So it's probably, it's the age of the patient, which after being discussed in the heart team, it's the age, the number of surgeries, and the comorbidities. This slide shows you the mechanism of failure, and the commonest is mitral regurgitation, followed by mitral stenosis, and then a mixed etiology. The symptoms are classical symptoms of NIHA or heart failure symptoms, shortness of breath. Being mitral patients, there is no surprise to have around 25 to 50 of atrial fibrillation. The procedure information, all transvenous, transseptal, and it's all under GA, and all TE guided. About these two patients who had conscious sedation, it was done without TE guidance. It was these are the patients who had complications. One of them got aborted procedure, and one of them needed emergency cardiac surgery. All patients had Edwards because we have only Edwards and Evolut R, so the only available suitable valve for mitral valve and valve will be Edwards in our cases. And these are the sizes. We expect most of the patient to be 25 and more when it comes to the mitral. One needed to be converted to surgery, and the reason is that it was done without TE guidance. It was done by only fluoroscopy, and that's the reason he needed emergency mitral valve replacement. The average or number of hours in CCU is probably 1 day. Next day, he should be to the floor. 30 days mortality, luckily no mortality in 30 days, but two patients had mortality after more than 30 days. One of them, the one converted to surgery, and the one was after the 30 days. Cardiac perforation happened in two patients. One of them is the same patient who was done without TE guidance, and the other was a pseudoaneurysm, small one, which was seen immediately at the procedure, and the surgeons consulted, but they thought it would be fine, and after 2 months it increased in size, so she was taken to surgery. We had only one patient who had stroke. It's the same patient who went to surgery, so you cannot really count the stroke on the mitral valve and valve. It was complicating the emergency surgery which was done. The CRRT and the need for dialysis is again the surgical patient. The ejection, you can figure out that the ejection fraction didn't change, but the significant thing is the drop of pulmonary artery systolic pressure and the gradient, and particularly in those with mitral stenosis. And this should be the case, should be immediate in front of your eyes. When you put the valve, you should really demonstrate that the gradient comes down, and if you have hemodynamic, you will immediately see the tendency of drop of pulmonary artery pressure. So this slide shows the change at baseline and discharge for the MR, for the MS, and MS on discharge 0. Patient had the remaining gradient, but the mitral regurgitation, you can have mild to moderate. This is a 7 months follow-up, and the number of patients is 18 because 2 patients needed to go for surgery. The mortality is 1. This one patient is the lady who had pseudoaneurysm, which increased at 3 months later. And 2 patients needed mitral valve replacement. One of them is the emergency surgery, and the other one is a pseudoaneurysm. Because the surgeon, when they want to treat the pseudoaneurysm, they have to take the prosthesis out to move the heart, and then you put a new prosthesis. Only 11 patients needed rehospitalization. And this implant surgery, the same patient who had pseudoaneurysm. At this 7 months follow-up, most of the patients remained in low NIHA class, so the response or the benefit was maintained for 7 months. Now, I will show you some of the echoes, one of the cases we did. This shows you the the bioprosthesis which degenerated and stenotic. And we use 3D always to show the same thing. In fact, we have excellent imaging team. This is one of the cases which has a stuck, one leaflet is stuck, creating stenosis and regate, and it's mainly stenotic. The gradient here is 10. I will show you clips of this procedure. So we do under TE general anesthesia and make use of the fluoroscopy, of course, and you can show the step on both fluoroscopy and by doing TE. Now, transeptal puncture, you don't need really to match the transeptal puncture of mitral clip. You need to go posterior because the mitral valve is posterior anatomy, but you need really to use the fluoroscopy to direct you where to go. Probably the best is in the middle of the septum, but you have to go RAO usually, and you see match or choose the point which gives you direct accessibility to the mitral valve. You don't need to go high, otherwise things will curve in the left atrium. So you go posterior, and then you decide. You don't need to be superior. Probably in most of the cases you will discover that you need to be in the middle of the septum, and you use the RAO view fluoroscopy. So you have to use both fluoroscopy and TE, and which makes accessibility is very easy to go. And we found from these 20 cases that probably the middle of the septum is better than superior. Now, you can use Agilis catheter, which is very expensive. Initially, we always try with sheath and Judkin-Wright Special, which is a good catheter used mainly by the pediatric interventionist, but we found it very useful. You pass with Judkin-Wright, you pass a Terumo wire, and then you slide it over to the left ventricle, and then you can put your Convida wire. When you are there, then it's probably half of the procedure is done. You have to go and dilate the septum, and most of the cases we use 12 millimeter balloon, but if the size of the Edward 29, probably it's safer to use 14 millimeter balloon to be able that you will not have any resistance in crossing. And I'm sure those who did it, they know the technique with Edwards. You just reverse whatever you are doing in TAVI, transaortic Edwards, okay? This is important. So the main thing here is to dilate the septum, and when you dilate the septum balloon, wait there. Don't inflate and deflate. Just wait for like few seconds, like 10, 30 seconds probably, so that you minimize the chance of recoil. And you don't dilate the septum while your team didn't prepare the valve. So you dilate, you come out, everything recoiled back, and then when they are ready, as if you hadn't done anything. So I think you need to have this harmony when you work in the team. Probably when they are almost preparing and ready, just go there and dilate the septum and wait for 30 seconds, come out, and then you introduce your device. Now, I don't know whether you will be able to see the prosthesis here. It's Epic from St. Jude. It's a thin, marker. And there is an app. I have the mitral app on my iPhone, you see. So you have to, if you want to do the procedure, you have to upload it in your iPhone, and you know the sizes, you know even the procedure. So you go there, you make sure of the position, you see, and there is no hurry. You have all the time to adjust your position. Now, I don't know, maybe in Professor Corti, they pace during mitral valve replacement, or valve and valve. We never paced. So this is the other probably thing which you didn't do compared to the literature. We have never done in these 20 cases CT scan, because we were sure from the work of our surgeons, and their reports are complete, and I'm happy to see one of our surgeons there at the back, Dr. Huda. And the label is always there, so we were sure about that. So there is probably no point of doing CT scan. The other thing is that we don't do pacing. We go without pacing. And you can have all the time. Can I have my slides, please? Sorry to take extra time, unless you want me to stop It's okay. So you see, you have to confirm the position. Thank you very much. And then you go slowly. You have to have harmony with the second operator who's inflating, because you are a primary operator adjusting and he's inflating. So he has to listen to you, and you need that critical moment of inflation. Now, the other point I want you to see here is this sheath. Now, you see the 3 dots. You have to pull the whole sheath beyond the third dot, because that's a soft part. If you lift it here while manipulating, this sheath might push your valve inside the left ventricle. So you have to double check all these. So the sheath should be withdrawn so that you don't have any problem by the sheath pushing the valve into the left ventricle. And you go inflating, and we use both. We look at the fluoro, and the echo is talking to us. Okay, you are fine, your position's fine, go inflate. And the initial should be slowly, because you can adjust. And when you are there in the middle, you just go fast. Okay? Now, it's our routine to put, for a small valve, 23 and 25, to put 1 cc extra. And for 27, 29, we put 2 or 3 cc extra for the purpose of flaring. And the flaring is towards the left ventricle, because this mitral valve is a closing valve, high pressure closing valve. So if it might migrate, probably if you left it there, if it didn't migrate to the ventricle because of the operator, it in the future might tends to migrate maybe towards the atrium because of the closing pressure. So you have to flare towards the ventricle side. Now, from the atrial point, because the skirt towards the atrium, you have to protrude 2 millimeters to make sure that there is no paravalvular leak. So these all fine details are very important. Sometimes you need to post-dilate to flare to the ventricle. And this is a good sign. When you see, we like to see this in profile. So the whole valve in front looking at us is well deployed, and the 3D confirms the good results. Then we do post-procedural echo while still in the OR, and you make sure of you see, it's the same patient. You have seen the stuck cleavlet. Now everything is fine. There is no MR. And the gradient, if you avoided the contamination, the gradient is only 4 instead of 10. And of course, there will be a created septum by the procedure. And in all patients, we didn't need really to do anything for that atrial septal rupture. And there is no shunt at follow-up. Thank you very much.